those were excellent presentations, and now we're going to start a 20-minute live discussion, question and answer, and this will be directed by moderators from both sessions. Dr. Kaneko and Belli and Dr. Herman and Sketong, can you guys unmute and start reading the questions from the chat room, and then the respondents can reply by unmuting.
Hi everyone, can you hear me? It's Olivier speaking.
Yes, Olivier. Yes.
Thank you. It's a real pleasure and honor to co-chair this session with my prestigious colleague. And I would say, just to begin an introduction, Dave, that's congrats for the organization and congrats to your team, local team. And I wish to everyone a fantastic and a successful meeting. We have a couple of question, but maybe I would leave Paolo ask the first one who made the comments.
Yeah. First to Horatio, would you think the robotic approach would be better for this complex reconstruction for someone without your exceptional skills?
Thank you, Paulo, and thanks to the Machado that made that comment by saying exceptional skills. I think that's all relative to what is the surgeon's preference. Believe it or not, I feel more comfortable doing it laparoscopically with the small needle driver and small needles, but doing it robotically is perfectly appropriate. I just think it's a surgeon's preference. Thank you.
And Horatio? Hi, Horatio, Olivier speaking. And do you think that maybe you would be more comfortable for the artery reconstruction using the robot? But in that case, you leave the right artery. It's okay. I mean, there is no discussion about that, but you have an attempt to reconstruct the artery. Maybe with the robot, it should be a little bit more easy to do that, no? Do you think?
No, I personally don't think that would have been easier with the robot. The problem is as we were stitching, because it was so small, we had a little bit of separation of the intima. Then I thought to myself, it may develop a pseudoaneurysm or a dissection, and I better would just do it. I don't think it was a matter of skills. It was not difficult. In fact, reconstructing the hepatic artery is so much easier than suturing a 2-millimeter pancreatic duct to the bowel. Then that's the advantage that you know, the ones that do pancreas and liver surgery have in terms of the suturing. But thank you.
There's another question to Professor Esban from Lanawi. Professor Esban, sacrificing the hepatic artery was conceivable because the bile duct was dissected?
I'm sorry, can you repeat it again, please?
If resecting the hepatic artery, if ligating the hepatic artery was conceivable because the bile duct was resected?
No, it's just because you end not having another option. The other option would have been to just reconstruct it with a graft and cutting a little bit further. But I personally, when you have done a lot of the bile and so on, you prefer not to keep a graft there. And also you have the chance of seeing how the liver is going to be doing after you clamp the artery for a while, right? The right hepatic artery. You can do an ultrasound at the beginning. It does get a little bit decoloration, but then you can wait for a little bit, and the collaterals fill, and the portal vein fills the rest of the liver. Then you do have to have that. And interestingly enough, this patient had a very minimal alteration of the liver function test, and I have no explanation of that other than the concept that each patient has a different percentage of blood supply to the liver from the portal vein or the artery. Other patients, very rarely I sacrifice the right hepatic artery, but other patients do have a much worse impact temporarily on the liver function test.
Okay, may I make a comment?
Yes, of course.
Okay. Horacio, great video. I really appreciate it. I have a question I mean, probably is not related to the minimal invasive surgery. What do you think about to do arterialization of the portal vein? Because in some cases we did it if we have to sacrifice the right hepatic artery and we don't want to do a right hepatectomy.
I'm not sure what you mean by arterialization. Maybe my own ignorance, but I would like you to. I mean, maybe a concept that is well known, but I'm not sure I know what's arterialization of the portal vein.
Is to reconstruct. I mean, to do an endolateral anastomosis between the right hepatic artery and the right portal vein. This has been described also in some cases, and I think also in some liver transplant cases. So there are some papers about that, and we did some cases, and I'm telling you, the result is pretty nice.
That seems to be a great idea. Now, my question to know if I'm the only ignorant or not is, for the rest of the panel, how many of you have done that arterialization of the portal vein? Is that common? Thank you, Luca. That's a great concept, but I don't have any experience.
Hello?
Horacio, I agree, this is a niche. But in that case, the roof of the biliary confluence was okay, so there is a supply which is enough. I totally agree with you, Horacio. No need for arterial reconstruction. Maybe we have to move on for other questions, and especially there is some question about the caudal approach.
I have one comment. Zenichi
Yes.
from Japan. We sometimes do the arterialization of the portal vein because that is a matter of not liver function, but a matter of blood supply to bile duct. Bile duct blood supply is from artery. So we are thinking about when we cut the right hepatic artery, we are thinking about blood supply or oxygen supply to bile duct anastomosis. So in that case, we sometimes
just give me 1 second.
arterialization of portal vein in Japan.
Thank you.
Horacio, can I make a comment?
Yes, of course. Thank you.
In patients who have biliary obstruction, and particularly who had been instrumented and have stents in place, sacrificing the right or left hepatic artery without removing the liver does put them at pretty high risk for infection, liver necrosis, etc. Typically you can get away with it. Sometimes in my practice, prolonged course of antibiotics might help prevent that. But it's a real risk, and this person I think did very well, but they were lucky, and I don't know that arterialization is the answer, but I think prolonged course of antibiotics might actually help prevent problems.
Thank you, Bill. What would you have done on this case? Would you have done a liver resection?
Potentially, if there was a sufficient liver remnant volume, particularly with the problems you were having with the margin. I mean, ultimately you got a negative margin, which of course is the objective. Certainly it increases the morbidity to do a bigger resection. No, I think the operation went very well. I would have been nervous about taking the artery, and like I said, I've done it. Some patients have done well relatively, others have had problems, and I've had some that have done really poorly with that. So it's I obviously worry in that setting.
Yeah.
So
can I make a brief comment?
Yes.
Just to extrapolate on that, because we have a reasonable experience of doing a hepatic artery, right hepatic artery ligation in cases of carcinoma, gallbladder, neck tumors, and in which even if we have ligated the right hepatic artery, we have not gone on to do a extended right hepatectomy, and we have still done a segment 4B5. And we have been reasonably happy with our results with that. I mean, we did have an occasional bile leak in the post-operative period, but it was not so significantly dangerous as I think some of the speakers have talked about, and we have been reasonably happy. We presented this paper in the IHPBA meeting, and in fact, in Korea, we had presented. Thank you very much.
There's a question to Dr.
I have one
Machado.
question. My name is Kaneko. I have the question. I have moderate the first session, so I'm asking the first session speakers. Professor Morise, how are you?
Fine.
You have a
How are
nice
you?
presentation,
Oh, thank you very
and
much.
I'm so much impressed. But my question is there any examination of the abdominal adhesion before the repeated laparoscopic liver resection? Because abdominal adhesion is the most obstacle for repeated hepatectomy. In our center, abdominal adhesion is routinely evaluated by abdominal ultrasound. We check the bowel movement between the abdominal wall and liver and makes the adhesion map. It helps a lot for the repeated hepatectomy. So any idea for that?
Yeah. Thank you very much for your question. I also use your technique for ultrasound, extra abdominal ultrasound before pre-operative ultrasound for making the mapping of adhesion. I also use that. And there's a two aspect for the adhesion for repeat hepatectomy in laparoscopic. There's one aspect in after laparoscopic liver resection, there's less adhesion. It's one of the advantage of lap liver resection. And also there's the other advantage of lap liver repeat liver resection because we can get good access to the surgical field without total adhesiosis of whole abdominal field. That is another advantage of lap liver resection, I think. But that is just for the small resection, because if we want to do right hepatectomy or left hepatectomy, in that case, we should do adhesiosis totally anyway. So that depends on the situation, but these are the advantages for lap repeat liver resection.
Thank you very much. And also, I have some comment to the Roberto Trozzi's presentation in the child B patient. And of course, everybody believes the laparoscopic liver resection has a great advantage compared to the open liver resection. But child B patient is operative procedure was so limited, just minor resection or a small piece of resection. So next time we are very much expected to compare with the ablation therapy. We have to compare to the ablation therapy in child B patient. That is my comment. Thank you very much.
Thank you, Hironori. I think this is a very good comment. Although the lesions were, the average mean was less than 3 centimeters in size, there were some lesions up to 5 or 5.5 centimeters, of course, located in very easy segments, easy positions, mostly in the anterolateral segments and away from the major hepatic veins. I believe that the ablation, especially microwave ablation, may give similar results for small lesions. So maybe even child C patient with no chance for transplant, which is the final therapy, as everybody knows, in appropriate circumstances, may be beneficial. But the problem is whether you are crossing the limit of the 3 centimeter in size. Maybe if you can approach with minimal invasive technique these lesions, it will be better, I guess, in terms of less tumor recurrence. But for lesions up to 3 centimeters, it's evidence-based that you can get similar results by doing ablation therapy. Thank you for your question.
Thank you very much, Robert.
Professor York, may I make a question, please? you hear me?
Yes, Julio, go ahead, please.
Yes, yes. I have a question for all the speakers of the first sessions about the repeated liver resection for SCC. Do you think that the feasibility of more and more repeated liver resection can modify the indication for liver transplant in salvage liver transplant? Because the feasibility and the low morbidity and mortality of the repeated liver resection, in my opinion, could be the possibility to reduce the indication for liver salvage transplant. What do you think about?
Questions for?
Oh, please.
No, go, Zenichi, please.
Yeah, thank you. This is an important point. I think I have actually 5 times resection patient, a few patients, but I believe some of them can go to transplantation. So in Japan, in our situation, that is a little bit difficult to get the donor for them, but that depends on the situation, and we should take some option for transplantation in that kind of case. I agree to Julio, and that is important point, I think.
Thank you.
If I may add just a comment, I think there is no modification of an indication for transplantation, but rather tailoring the therapy to the patient. So patients who for some conditions are a little bit more at risk for transplantation, maybe you can use this iterative therapy, but the transplantation is the final solution for many of these patients. So I think we have to be careful.
I agree with you, but the problem is to delay the transplant. That is the point for the repeated liver resection.
That's why you tell to the patient, to the age, to the morbidity, to the local resource, to availability of live donors. You know that there are many circumstances that should be evaluated at the same time.
Okay. Anyway, congratulations to all the speakers.
Julio, I agree with you. So, yeah, for repeat dissection, so we can say you can have more treatment for the recurrent HCC. So, as other speaker already mentioned, there are many variety of treatment for the recurrent cancer. So one may be the repeat resection by laparoscopy, or one maybe another is ablation, another may be the TAC. So depend on the tumor location and size and multiplicity, we have to choose the treatment. So, and the liver transplantation may be the one treatment, but as already Janice Morris already mentioned that if we have not donor, so we have to choose another treatment like repeat resection or ablation or TAC. But anyway, so if the indication for resection is necessary, I think repeat liver resection by laparoscopy is a very good treatment option, especially compared to open repeat resection. Laparoscopy repeat resection has less adhesion, so that's why it is better to have a multiple resection for the recurrence cancer. Thank you.
Thank you.
I don't know if we're running out of time, but
we have time for one more question.
Okay, we have a question here for Dr. Machado about what's your concern about biliary anatomic variations and the use of your extrahepatic Gleason approach?
Okay, this is a common question every time we talk about Gleason approach. So since 2001, when we described our technique together with Paulo Herman here in Brazil, we are answering these questions. Usually the Gleason approach as it enters inside the liver parenchyma, the biliary anomaly or variation was already take place. So whenever we do an inside glycemic approach, far from the hepatic hilum, usually the biliary anatomy, biliary variation was in the hepatic hilum itself. So whenever you go up about a half centimeter, 1 centimeter inside the liver parenchyma, the biliary anomaly was already take its course. So usually we don't see this. But of course, whenever you know preoperatively that we may have a really rare biliary anatomy, we may take care. It was seen in one of the presentations showing that sometimes we have the biliary tract from the posterior crossing the anterior right posterior right sector, and if you clamp the pedicle above this biliary cross, we can
Can somebody stop sharing their screen? We lost the audio.
Oh, no, I'm here.
Okay, thank you. So last comment, Marcel, and then we will go to an industry break and bathroom coffee break.
I need the coffee at the bathroom takes also.
Okay, well, we're going to stop now, and we have about time for a 7 or 8 minute break, and we'll resume at 10:50. You won't want to miss it because we have outstanding best plenary videos starting in 7 minutes. And also during this time, for the 330 participants and the faculty, please click onto the industry. If you look on the Attendify platform, on the left side, it says sponsors, and then you can click on and look at tremendous videos and technology. For the faculty and moderators that log in through Zoom, you have to log in through the Attendify app to get to the industry sponsors. So we'll see everyone back in about 7 minutes. Thank you.